So talking about anti-reflux surgery or correction of acid reflux. So when do we do that? There are several conditions. Number one is patient's choice. When the patient says, I don't want to have the complaints, it is really affecting the quality of life. I don't want to be taking medications for life. I want my reflux corrected. Patients that have a large hiatal hernia are predisposed to having more symptoms of reflux. That means the condition where the stomach is moving up into the chest. And it's because the valve is out of place. So that may require surgical correction of the hiatal hernia to put the stomach and the esophagus where it belongs. Other conditions when we do them is when the patients fail medical management. You have been taking medications, you've made dietary modifications, you still continue to complain of reflux, then it's time to correct it. So other conditions where we may have to correct the acid reflux is if you have complications of GERD, such as severe esophagitis, severe burning, or a narrowing of the esophagus. There are other conditions where patients have atypical symptoms that are more predominant with cough, asthma, aspiration, sore throat. Those patients do not tend to respond well to medications, but they respond better to surgery. And ultimately, it's a patient's choice. So luckily for you as a patient is that therapies for surgical correction of reflux should be covered under health insurance. That means it is mandated for most insurances to cover treatments for GERD. Now, my goal when treating GERD or correcting the reflux on the patient is that I need to have several things accomplished. Number one, we're talking about a one-way valve. It's a valve that allows you to swallow the food, goes into the stomach, but at the same time, it has to prevent the acid from coming from the stomach into the esophagus. So I need to restore the function of that valve. If the valve is weak, I need to make it stronger. If the valve is out of place, I need to put it in the right place. If the valve is opening when it's not supposed to, I need to stop that. But in correcting the reflux valve, we also need to preserve the ability for normal body functions, such as swallowing, the ability to burp and belch when it's necessary. So it is not like a hole that you can patch. It is something that has to be properly adjusted based on the individual patient. So let's talk about one of the endoscopic treatments called Stretta. So the Stretta procedure is non-surgical. It is totally performed through the mouth. It is similar to an endoscopy. So what we do is that we mark all the landmarks in the stomach and we advance a special catheter. This catheter is accompanied by special needles that deliver energy into the muscle that is weak at the lower esophageal sphincter. So we have different regions of treatment with those needles, and this is totally performed through the mouth. What we wish to accomplish is delivering a controlled energy into the muscle so that the muscle over time strengthens, becomes less resistant to opening, and also to treat those abnormal relaxations that the muscle can have leading to acid reflux. So as you can see in the demonstration of the video, this controlled energy over time will cause more competent muscle. So as you can see from the video demonstration, this procedure is totally performed through the mouth. It does not require general anesthesia, so it is performed under controlled sedation. It is ambulatory, the patients go home same day, it has very good results. It is a wonderful procedure for patients that have inappropriate opening of that muscle valve leading to reflux, and the risk of the procedure are extremely low. So some of the limitations that the procedure has is that it cannot be performed on patients that have larger hiatal hernias because it is not a procedure to restore the mechanical problem within the esophagus and the stomach. It is a procedure to help the muscle work better. Another limitation of the Stretta procedure in some cases is that it requires a little bit more of a fight to get insurance approval for it, but ultimately it is obtainable. So now let's switch topics and talk about the transoral incisionless fundoplication, also known as non-surgical fundoplication. So the goal of the endoscopic fundoplication is to restore the function of the valve and prevent the valve from opening when you eat or during gastric distension. We perform this procedure to accomplish a lengthening of the functional muscle, and it is totally done through the mouth, simulating the actual surgical procedure known as fundoplication. We will talk about the fundoplication later during the discussion of the seminar. So this procedure is through the mouth. We have a special device that we insert into the esophagus and advance down into the stomach. We have a special camera to visualize all of the anatomy of the stomach and the esophagus. Once we have the device and camera into position, we then proceed to create and reshape the fundus of the stomach to give it that effect of a partial wrap. So as depicted in the video, we pull the fundus and the functional muscle into the device to start creating a little wrap. The function of this wrap is to prevent the acid from coming up. But notice that we have a device inside of the esophagus, and that guarantees that you will have all the necessary space for the food to come down into the stomach when you swallow. We launch some special anchors that will keep the stomach in place. Those anchors are absorbable. Later on, they become part of you. So they're pretty much made of vinyl. They don't represent any risk of infections or anything like that. And ultimately, your body incorporates them and absorbs them. You can see in the video how reshaping that, we are creating that shape of a fundoplication. So now the muscle is more functional, it is longer, and when the stomach distends, it doesn't tend to open as it would if the stomach muscle will be weak. So it's a good prevention for reflux. It's a replica of the surgical procedure, but now performed totally through the mouth. And the good thing is that it's an ambulatory procedure. Patients go home same day. So one of the greatest advantages of the TIF procedure is that it can be performed totally through the mouth with minimal risk. One of the disadvantages is that we don't have long-term follow-up results as to tell what are going to be the expected outcomes 10, 15 years down the road. It may be considered investigational by some insurances, and it has moderate to good results. So the therapies for reflux will have better results when they are surgical than when they are endoscopic. But overall, the chances that you'll be off medications 2 years to 5 years with this type of treatment ranges anywhere between 60 and 80%. So now let's switch topics a little bit and talk about the surgical options, especially the LINX procedure. So let's start with discussion of the surgical options with the LINX device. So the LINX is a set of magnetic implants, such as this. This device is placed around the esophagus by minimally invasive techniques. That means tiny little holes in your belly. And the function of this device is to restore the functionality of the lower esophageal sphincter, the functionality of the one-way valve of the stomach. So when we put it around the esophagus, we have to measure the esophagus before we place the LINX so that we can place the appropriate size based on the patient. When you eat, the squeezing of the esophagus of the food makes the device open. The food goes down into the stomach, and when you're not swallowing, the device contracts to reestablish the competency of the valve. It is an implant. That means that it can be placed, but also, since it's an implant, it can be removed if it causes any problems. What I like about the LINX is that it has very good long-term results at correcting reflux. We're talking more than 90% of the people completely come off the medications. The procedure is performed in an ambulatory setting. That means the patient gets to go home the same day. In some occasions, the patient can stay overnight in the hospital. So it's a very well-tolerated procedure. It is a very safe procedure in the expert hands. Fortunately, I perform a lot of these procedures, and I am a proctor for other surgeons that want to learn how to perform the LINX procedure throughout the country. So they required special training by a surgeon like myself. And I have the fortune of dealing with a lot of patients that have had tremendously great results from receiving this therapy. So let me show you a quick video about how the LINX works at correcting reflux. So very briefly, we're going to show you a diagram of how the LINX works. So as you can see, the ring is placed around the incompetent lower esophageal sphincter. You see the esophagus, and the acids are still maintained within the stomach. So the LINX allows the food to normally flow into the stomach, and the competency is restored to prevent the stomach content to reflux. This is a very easy demonstration of how LINX prevents acid reflux. So one of the things I like the most about the LINX device is that patients start eating regular food from the day zero. So immediately you start having regular food so that you can exercise this band with the swallowing. Just like you would have a knee replacement, the way you exercise a knee replacement is by walking. The way you exercise the LINX device is by swallowing. Okay. Many patients do experience some transient degree of weight loss, and part of the issues and the reasons why they develop a little bit of weight loss is because they have to adapt initially to a slower eating so that the food can go down easier through the LINX. Remember, before you had a pretty incompetent valve, it was widely open, so it was a lot easier for the food to go down into the stomach. Now we're restoring the efficacy and efficiency of that, and because of that, you have to chew the food really well. But the patients start having regular food from the get-go. The risk safety profile from the LINX is extremely good. The chances of any complications or major problems arising from the device are extremely low. There have been reported cases of erosions. There have been reported cases of removals. But that being said, most of those procedures have been performed safely, and the chances of having any problems from that is in the 0% percentage rates. That makes the procedure extremely safe. So let's now switch topics and talk about another surgical correction of reflux, which is the fundoplication. So the gastric fundoplication has been long recognized as one of the gold standard surgeries for correction of reflux. There are newer therapies that have been developed over the last 15 to 20 years. The gastric fundoplication has a longer establishment date. So what we try to accomplish in the gastric fundoplications is that we utilize the body's own tissues. And by that I mean the fundus of the stomach. We create a wrap around the esophagus that will restore the competency of the valve. It will also prevent the valve from opening when it's not supposed to, or from opening when you eat. We need to create the valve loose enough at the same time that would allow you to swallow the food normally into the stomach. So it's a very well recognized surgery, has excellent results, more than 90% correction of acid reflux on the long term. The chances that you come off completely the medications is also close to 90%. But you do require certain technicalities of it. So this is a procedure that in expert hands has wonderful results. Remember that we are adjusting a valve to work appropriately, allow you to vomit, allow you to burp, allow you to belch, and while maintaining the ability of the patient's capacity to swallow the food normally. So the gastric fundoplication is performed through minimally invasive techniques. That means tiny little holes in the belly. It is a procedure that requires very short hospitalization, maybe 1 day in the hospital at most. I personally give the patient contrast to swallow the next day after surgery just to make sure how the food is going down into the stomach. They may experience some swelling initially, and that tends to fade away. We transition the food slowly with the fundoplication. The first few days, the patients are more on a liquid diet because of the swelling, and then we progress it to soft, regular diet over the next 10 to 14 days. So by 2 weeks period, the patient is already having regular food after this procedure. So the gastric fundoplication has the ability to reestablish that strength because it is more of a surgical procedure as well. It carries a slightly higher risk of other problems. Those other problems could represent difficulty swallowing in up to 1 to 2%. Also, it makes it more difficult for the patient to burp and belch or to vomit. So we are readjusting the valve, and because of that, it could actually have a little bit repercussions in up to about 1 to 2% of the patients, with making it more difficult to handle that. Now, on the contrast, that means that most patients do not experience any problems. We're talking about 98 to 90% of the patients. Another aspect of the gastric fundoplication is that we tend to tailor the fundoplication based on the patient's esophageal function. So for example, if a patient has normal swallowing function in the esophagus, we tend to create just a regular 360-degree wrap, whereas patients that have problems swallowing or a weak esophagus, we tend to create more of a partial fundoplication so that we don't create too much strength to the swallowing function. So we have to create a complement between correcting the reflux and the patient's ability to swallow. That's our main focus when we actually perform any therapy on the patient. So let me just show you a quick video demonstration about what a fundoplication wrap represents. So this diagram shows you what an Nissen fundoplication is. So fundo refers to the fundus of the stomach, which is the top, more bulgy portion of the stomach. And plication refers to the action of folding the stomach around. As you can see, we grabbed the fundus to recreate the normal valve. This procedure is done through tiny incisions as depicted in the diagram, and in rare, extremely rare occasions, it may require an old-fashioned cut. If the patient has a hiatal hernia, that is repaired at the same time of the procedure because we need to reestablish the normal mechanical position of the valve. So the wrap is created as stomach to stomach and sutured together. After we suture it, we tend to create more of a 2 centimeter long valve so that it's not so restrictive for the passage of the food, but at the same time protecting you from having reflux. Results after Nissen fundoplications are excellent. Most patients are able to come off the medications completely in up to 90-95% of the times. So let's now switch topics and talk about a special procedure for acid reflux, the gastric bypass. So most of you don't recognize the gastric bypass as a procedure for acid reflux. It is most commonly known as a procedure for weight loss. What we have seen over the years is that most of the procedures performed for correction of reflux, they have a high failure rate in patients that live with morbid obesity. And by that I mean body mass index over 35. So that leaves a great deal of patients that are not eligible for acid reflux conventional surgery, but at the same time they have a problem with the weight. We said earlier that 1 out of every 3 patients with obesity also have acid reflux. So what do we do with those patients that live with morbid obesity and at the same time they have chronic non-responsive to medication acid reflux problems? So I guess the gastric bypass is the answer to that question. So we're briefly going to tell you about the pros and cons of the gastric bypass. We're going to tell you about the main advantages and disadvantages of the gastric bypass. We're also going to show a video demonstrating how the surgery is performed. So one of the main advantages of the gastric bypass nowadays is that the chances of correcting acid reflux in a patient with morbid obesity is more than 95%. It has also excellent resolution of comorbidities including diabetes, high blood pressure, sleep apnea, high cholesterol, and many other obesity-related problems. So what would be the ideal way to treat the obesity and all its associated problems and to also correct the reflux at the same time? Makes the gastric bypass a wonderful choice. Some of the disadvantages of the gastric bypass is that we are creating an alteration of the intestines that will help you lose weight, but with that means it requires some extra care from the patient. What are the things that you should follow? Vitamin supplementations to preventing you from going low, calcium supplementation, iron supplementation, and you need your regular scheduled follow-ups. Luckily, the gastric bypass is a very safe operation in expert hands. The chances that any complication arises from a gastric bypass is less than 1%. With that being said, we're going to show you a quick demonstration about how the surgery is performed. So in this video animation, you can see an example of how the gastric bypass procedure is performed. Similar to any other minimally invasive surgery, small punctures are created into the stomach that allows the surgeon to place specialized cameras and instruments to visualize the inside of the patient. We have the stomach, which is a large container, 2 to 3 liters of food at once. We turn it into a small pouch of the stomach. We then perform a reconnection of the intestines to create a pathway of malabsorption. This enables the patient for further weight loss. So the bypass primarily works by two different mechanisms. It restricts the amount of food that you can take, but it also creates a small pathway of malabsorption. Bypass by definition means that the food is rechanneled to a different pathway. Ultimately, the juices of intestines and the food mix for a normal absorption. As you can see in the video and the discussion of the gastric bypass, it is a surgery that ultimately was designed for weight loss, but it has tremendous advantages at correction of reflux.